The goal is to learn the innervation of the anterior canal, lateral canal, and posterior canal, as well as the utricle and saccule. So, a quick summary. A superior vestibular nerve innervates the lateral, the superior, and the utricle. The inferior innervates the posterior portion and the saccule, which has an asterisk here because the superior vestibular nerve does have fibers that go there. We're going to see a case, but first let's focus ourselves with a question. Which of the following is the most likely etiology of this patient's initial episode of vertigo? The differentials are going to be Ménière's, vestibular migraines, BPPV, superior semicircular canal dehiscence, lateral medullary infarction, which is also known as Wallenberg syndrome, vestibular schwannoma, vestibular neuritis, and labyrinthitis. So let's begin by reading the question. A 60-year-old man referred by his PCP for concerns of vertigo. Symptoms began 2 weeks ago with a sudden onset of sensation of room spinning that awoke him from sleep. He denies preceding illness, trauma, or change in medication. Spinning vertigo persisted for 3 days, most of which he spent in bed. Symptoms were present when supine, though less severe when still. He did not notice any change in his hearing or other audiologic symptoms with the vertigo. He experienced intermittent vertigo symptoms, for the subsequent 2 days, triggered by turning his head to the right while in bed, and lasting less than a minute. Last episode was 2 days prior. Episodes were not associated with auras, light, or sound triggers. He has not experienced any true vertigo since, but experiences persistent imbalance, unsteadiness when standing and ambulating. He notes increased difficulty without visual input. He denies ear pain, fullness, drainage, and ringing in his ears. He also denies hoarseness and dysphagia. He denies history of headaches, though notes his brother has migraines. He denies IV antibiotics, diuretics, chemotherapy, aspirin use, loud noise exposure, and head trauma. Past medical history includes diabetes type 2, hypertension, is on metformin and lisinopril, smokes cigarettes a pack a day for the past 30 years. So let's review the differentials that we had. Ménière's is usually episodic vertigo, less than 24 hours. This man had about 72 hours of vertigo. Unilateral low frequency sensory neural hearing loss. He's not even complaining of hearing loss. There's tinnitus and there's fullness. So the picture of Ménière's does not fit with the case we just had. And also less than 24 hours is for probable Ménière's. Definite Ménière's is 12 hours. Vestibular migraines, episodic vertigo but persistent unsteadiness in between episodes, light sensitive, motion sensitivity, history of migraines, normal audio, normal balance function tests. BPPV, episodic vertigo with positional component that lasts seconds, no tinnitus, no hearing loss. However, the question asked, which of the following is the most likely etiology of this patient's initial episode of vertigo? Perhaps he had BPPV over here. Next, superior semicircular canal dehiscence. This presents with episodic vertigo precipitated by loud sounds or pressure changes associated with hearing loss, tinnitus, and possible history of trauma. Lateral medullary infarction, this sudden vertigo associated with dysarthria, hoarseness, and Horner syndrome. Stroke risk factors, like this patient had DM, hypertension, smoker, but overall does not fit the picture. He didn't have hoarseness, no dysarthria. Vestibular Schwannoma, it could present as a progressive unilateral hearing loss, sensory neural. Typically, you could have unilateral tinnitus. Facial nerve paralysis in advanced cases, and acute vestibular symptoms like this man had is uncommon from a slow-growing tumor because there are compensatory mechanisms that the brain employs with a gradual loss of vestibular function, but not audiologic function. Vestibular neuritis, this is what this patient actually has. Sudden onset of prolonged vertigo days and no audiologic dysfunction, contrast with labyrinthitis that has the same features but plus audiologic dysfunction. On physical exam, his vitals are within normal limits. His pupils are round, equal round, and reactive to light and accommodation. Remember how we were talking about lateral medullary infarction where he might have Horner's syndrome. Tongue is midline, palate is symmetric and elevates symmetrically. Facial nerve function is intact. TM visualized and intact. No symptoms on pneumatoscopy. Weber lateralizes the left, and Ryan is negative on the left but positive on the right. This is a conductive hearing loss to the left. There's overt horizontal saccades with right head impulse test and vertical saccades with downward head impulses. A right Dix-Hallpike revealed a right beating geotropic nystagmus. Normal finger to nose test and normal tandem gait. Romberg is negative. Audiogram from the same day shows a mild conductive hearing loss in the left ear. Head MRI and CT done about a month ago brought in by disc were unremarkable. So there's a lot going on here, and I'm going to make another video that reviews the physiology and the findings for HIT, for geotropic nystagmus versus ageotropic nystagmus, why is it right beating. But that is beyond the scope for this example. But one thing I do want to point out over here, when I say vertical saccades with downward head impulses, the downward head impulses activates the anterior canal. And when testing for this, remember that you have to turn your head 45 degrees to the opposite side when you're testing for the anterior canal, so that the canal is 90 degrees to the frontal plane. In other words, imagine this is your right side and you want to test for the anterior canal. What you really want to do, you want to turn your head to the left 45 degrees so that the anterior canal is now 90 degrees to the frontal plane. And then you bend downwards and that activates the anterior canal. We'll go over this in another video. Moving on. Reviewing the physical exam and ancillary test findings. In Ménière's, hearing loss would be on the same side as vestibular dysfunction. In this case, Weber's, the left and right is negative on the left indicates left conductive hearing loss. And remember, he has the right side dysfunction as indicated by the HIT test. Also, hearing loss in Ménière's should be sensory neural hearing loss. Vestibular migraines would get normal HIT, BPV, normal HIT, positive dyshallpike, but question again is asking about initial episode. Superior semicircular canal dehiscence, you might find vertigo on pneumotoscopy, but not always, and you might see dehiscence on CT, in which his CT was unremarkable, assuming that the resolution was high enough quality. Lateral medullary infarction, pupils constricted on one side, pallid deviation, hoarseness, positive cerebellar test, finger to nose, tandem gait, which he was showing no signs of. Vestibular Schwannoma, again, facial paralysis and advanced disease. Mass would have been picked up on MRI. Vestibular neuritis, sudden onset and prolonged vertigo, no audiologic dysfunction. Remember, this is our answer. Labyrinthitis, we get positive HIT and sensory neural hearing loss, which this man does not have. So just to review HIT, this is an example of vert saccades in contrast to covert saccades, which really can't see with the naked eye. You need video systems for that. But over here, so you turn the man's head to the right, your VOR should have the eyes remain on target. In the pathologic case, you move the head to the right, and your vestibular ocular reflex that receives input from the vestibular system doesn't work. So instead, your brain, your cortical, then tells your eyes, hey, move back to the target, which is slower. Saccades is a little bit slower. It's 0.1 milliseconds, not controlled by the brainstem, unlike the VOR. VOR is very quick, hence why it's called a reflex. So again, you turn your head to the right, should be fixed on target, doesn't fix on target, therefore it is a right vestibular dysfunction. And quickly review that when your head is turning to the right, your VOR should be going to the left, and because it's not going to the left, higher processing centers in the brain take over and move your eyes forward. You also called saccades. Remember that your VOR is in the opposite direction of your vestibular activation, and saccades is in the same direction as your VOR. Again, we'll review this hopefully in another video. So what does this patient have? He had vestibular neuritis complicated by BPPV, and BPPV actually occurs in about 10 to 15% of patients within weeks of vestibular neuritis. It's a complication. A few words on vestibular neuritis. Inflammation of the vestibular nerve, thought to be reactivation of HSV1, therefore treat with steroids, just like Bell's palsy. Superior vestibular nerve is the most common. I try to find why, and all I get is perhaps it's because it's the bigger of the nerves, has longer canal, more susceptible to inflammation or entrapment. Prolonged vertigo for days, then residual symptoms gradually resolving over the following weeks. And I stress resolving, not just compensating, because your calorics will go back to normal values. Recurrence in about 2 to 11%, and like we said before, BPV 10 to 15% within weeks of vestibular neuritis. This is the crux of what I want to talk about in the video. What does the patient's subsequent BPV suggest? What it really suggests is that the nerve that supplies the canal was spared from the vestibular neuritis. BPPV is classically from the posterior canal, which is innervated by the inferior vestibular nerve, and it's predicated on a functioning canal. If the canal is not functioning, then there could be no symptoms. So there has to be a functioning posterior canal. And if that's the case, then posterior canal cannot be innervated by the same nerve that was affecting the vestibular system. So it has to be innervated by a different nerve, and that nerve is an inferior vestibular nerve that also innervates the saccule. What condition most commonly affects inferior vestibular nerve? So the answer to that is vestibular schwannoma. This is in contrast to vestibular neuritis. Two different conditions, two different nerves that it most commonly affects. how can I remember which nerve is involved in which condition? So remember that vestibular schwannoma are also called acoustic neuromas, which is a misnomer. The inferior vestibular nerve is close to the cochlear nerve. The cochlea is responsible for auditory signals, and again, the misnomer is acoustic neuromas. So you can remember that the inferior vestibular nerve is most affected by vestibular schwannomas. And the other one is the other one, Golgi. So what test can you perform to confirm a functioning right posterior canal? So no overt down vertical saccades are observed with upward head impulse. So I don't know why I wrote this so confusing, but when you do an upward head impulse with your head turned to the right at a 45-degree angle, you're not going to see any down vertical saccades. Why? Because your VOR is hopefully intact, and that will indicate an intact right posterior canal. Of course, you could use VHIT for more accurate results for covert saccades. Lastly, another explanation for this patient's clinical picture could be a vascular compromise to the anterior vestibular artery that will knock out both the superior and the horizontal canals, just like in vestibular neuritis, but you really can't tell the difference. There is an eponym for it. It's Lindsay-Hemingway syndrome. Initial episode with peripheral vestibular syndrome followed by recurrent episodes of BPPV, just like our patient had. And for those really into mnemonics, I heard a great one last week in clinic. You'll probably really like this if you're from Louisiana and love college football. LSU is superior, and the other one is the other one.